Reduction of residual ridges is the major problem the dentist has to face while restoring an edentulous condition, because this is a major disease entity affected by many factors and it is totally out of control of the dentist. Let us look at few common definitions. What is bone? Bone is highly vascularized, living, constantly changing mineralized connective tissue. What is alveolar process? It is the part of maxilla and mandible that forms and supports the socket of the teeth. What is alveolar bone? Is the bony portion of maxilla and mandible in which the roots of teeth are held by the fibers of periodontal ligament. What is residual ridge resorption? It is the term used to describe the diminishing quality and quantity of residual ridge after tooth extraction. Before you understand the pathology process of residual ridge resorption, you have to actually understand what happens following tooth removal. Following tooth removal, there will be bone healing. What are the stages in bone healing? Following immediate tooth extraction, in the first 24 hours, there will be hemorrhagia, bleeding and formation of blood clot. This happens within the first 30 minutes and after that it is the organization of the blood clot. In the next 48 to 72 hours after extraction, there will still be the blood clot organization and beginning of granulation tissue formation. As the days progresses, 96 hours after extraction, there will be granulation tissue formation, also epithelial proliferation. 7 days after extraction, there will be continued epithelial formation and also primary osteoid formation. 7 days following extraction, there will be first incidence of bone tissue formation and the healing continues to the further days. When you check it at the 21 days after extraction, there will be slight amount of connective tissue formation, also continued epithelial proliferation and mineralization of the primary osteoid takes place. Coming to 6 weeks after extraction, there will be re-epithelialization, connective tissue formation and woven bone and trabeculae are also seen following mineralization of the primary osteoid. Earlier, there was a controversy if residual ridge resorption is a physiology process or pathology process. It is both physiologic and pathologic. So, coming to the pathology of residual ridge resorption, the pathology can be studied under two subheadings, gross pathology and microscopic pathology. So, depending on the pace at which there is resorption, the tissues overlying the residual ridge will be varying from either redundant tissues to the excessive flabby ridges. So, how do you actually study the gross pathology? Residual ridge resorption is initially just a localized bone loss, but as it is progressing, you have to check each and every case according to the amount of bone loss. So, how do you actually check it? Clinical examination. Visual examination is the first thing which you have to do, but that is really not sufficient because sometimes the tissue may vary from inflamed to edematous, ulcerated, indented or otherwise abused tissue. Just in case there is flabby ridge, on just visual examination, you might feel that the denture bearing area is more, but on palpation you will come to know that the tissue is all flabby and the amount of residual ridge is very less. Hence, palpation is very important than visual examination. And what other processes can you confirm the amount of bone? Panoramic radiographic technique is one majorly followed technique which is and best dependable technique where you can actually study the amount of residual ridge resorption. Taking sequential panoramic radiographic techniques at subsequent follow-up visits will actually help you study the amount of bone loss happening in a particular patient. Tracings and overlapping of these tracings will help you study the exact amount of bone loss. In this picture, you can see two different lines. The solid line shows the amount of bone at present day situation, and whereas the dotted line was the amount of bone which was present earlier. So the difference between this dotted line and the solid line denotes the amount of resorption. Coming to microscopic pathology. In microscopic pathology, there will be increased evidence of osteoclastic activity. Osteoclastic cells are the bone resorbing cells. Hence, there will be increased resorption of bone. Also, increased variation in the density of osteoids, increased number in the incompletely closed osteoids, and also increased endosteal porosity. Coming to histology of this tissue, as it is a disease and aging process, you will see increased keratinization, increased acanthosis and edema. Coming to pathophysiology of residual ridge resorption. In normal function, always in the body, bone resorption is balanced by bone formation. Except during growth, where there is more of bone formation. In case of osteoporosis, bone resorption is always dominated by bone formation. In case of periodontal tissues, there is first initial incidence of slight localized destruction. If this is left unattended, bone resorption dominates bone formation, and the final result will be loss of bone. Coming to pathogenesis of residual ridge resorption. How does this ridge resorption progress? Following tooth removal, if you check the residual ridge, there will be rounded genial tubercle and also a socket of central incisor. And if you can see at third picture, it is the rounded crest of the ridge following removal. The alveolar structures which are like sharp projections will be rounded off due to continued stimulation of the surrounding tissues. And as the tissue is aging, the high rounded ridge will change into knife edge ridge with a sharp crest. And as the aging process continues, resorption also continues at a slower pace, and this sharp knife edge on the crest will be rounded off to low rounded structure. And as the disease progresses, it will end at depressed level of bone. Coming to epidemiology of residual ridge resorption. This is the most difficult task because residual ridge resorption is affected by a disease which is caused by many factors. So studying the disease prevalence and incidence was very difficult. Hence, it doesn't have any predisposition in any age. It doesn't have even sex predisposition, and it is not directly related to any health and illness. And it can even seen in cases where there are denture varus and even without dentures. And also it is unrelated to the primary cause of tooth extraction. So it is very unclear. Coming to the etiology. It is a multifactorial disease. What are the factors affecting residual ridge resorption? The factors include anatomic factor, metabolic factor and functional factors. All these factors act independently and also in various infinite combinations leading to residual ridge reduction. What are the anatomic factors? Anatomic factors include the quality and quantity of bone. Residual ridge resorption is directly proportional to anatomic factors. More the amount of bone, more resorption. Hence, high well-rounded ridges resorb more when compared to knife edge ridges. Coming to metabolic and systemic factors. What is metabolism? Metabolism is the sum of anabolic and catabolic reactions going on in the body. So in adult life, these two anabolic and catabolic reactions are in balance. What is anabolism? Anabolism is energy forming procedures. What is catabolism? Catabolism involves energy breakdown. So in adult life, they are both neutral, in the sense they are both balanced. Hence, resorption and formation are always balanced in adult stage. But whereas as the person ages, there will be imbalance due to sedentary life. So in growing age, anabolism dominates, where there is more of energy build-up than energy breakdown. In adult age, there is balance. In advanced age, catabolic reactions dominate, where there is more of energy breakdown due to sedentary life. So residual ridge resorption is directly proportional to bone resorption factors and inversely proportional to bone formation factors. What are the resorption factors? These resorption factors are nothing but the endotoxins which were actually released from the dental plaque which was present when the patient had teeth. Which means if it was a poor oral hygiene, that will even have bearing on the later stages of dental condition. Osteoclast activating factor is one factor which activates osteoclasts, which are bone resorbing cells. Prostaglandins following tooth removal, these are the mediators of inflammation which are released and which will help in bone resorption. And human gingival bone resorption factor is one more factor which will act in bone resorption. Ill-fitting denture is one important local factor which helps in more of residual ridge resorption. How does this happen? When there is ill-fitting denture, the denture doesn't really sit evenly on the denture base. So there will be improper distribution of loads. When there is improper distribution of loads, few areas pressure will be more, leading to occlusion of the blood vessels. Vascularity will be reduced, due to which there will be reduced oxygen tension, oxygen distribution to the tissues, leading to increased resorption. Coming to systemic factors affecting bone resorption. These factors affect bone in three different ways. Bone loss due to decreased formation, bone loss due to increased resorption, and bone loss due to unknown causes. Decreased formation usually happens in conditions like hypophosphatemia in the body, then if a more amount of glucocorticoid production like Cushing's disease, where glucocorticoids actually help in decreased bone formation, and in cases like autoimmune diseases where it is must and inevitable that you have to give glucocorticoids, in such patients you will see increased resorption of bone as a side effect of glucocorticoids which are incorporated in treatment. The bone loss due to increased resorption is actually seen in cases with hyperparathyroidism, and bone loss due to unknown causes includes genetical factors and also sedentary life. Coming to mechanical factors. What are the mechanical factors affecting bone loss? It is the amount of force which is distributed onto the tissues, frequency, not just the frequency, also the duration, the direction, and the area over which the force is distributed. So you have to consider the total force including function and parafunction. Coming to damping effect. This is one factor which is inversely proportional to the residual ridge resorption. Damping effect is the capacity of absorption of energy that is transmitted into the tissues. In simple terms, it can be said as elasticity or flexibility. This is actually seen in the mucoperiosteum of the bone. So more the damping effect, more forces will be actually absorbed. It is the stress absorbing mechanism of the bone. Mechanical factors in relation to prosthetic part. So broader coverage area of denture is must to help in distribution of forces, proper distribution of forces, and improved tooth form, also adequate interocclusal distance in rest position. If there is less interocclusal distance in rest position, the muscles will be very active and there will be continuous forces that are being applied on the denture base, leading to reduced oxygen tension and increased resorption. Coming to other factors, effect of surgical trauma, alveolectomy, and excessive load of ridge by poorly made dentures or overly retentive dentures. This will lead to continuous forces on the denture. And how does surgical trauma and alveolectomy affect? Following surgical trauma and alveolectomy, there will be inflammatory mediators released, which are prostaglandins, and this will in turn affect in bone resorption. So, coming to the summation of all the factors affecting residual ridge resorption is inversely proportional to the time. Following tooth extraction in the immediate 6 months to 1 year, the residual resorption will be very fast. The amount of bone resorbed will be more in the first 6 months to 1 year, and as the person is aging or the bone is aging, the amount of resorption will be less and it goes on at a slower pace. RRR is directly proportional to anatomic factor and also the sum of bone resorption factors by bone formation factors plus force factor and inversely proportional to damping factor. So all together summed up will give you the total net effect of residual ridge resorption. So now that you know the factors affecting the residual ridge resorption, now you have to study the resorption patterns in each bone. So how does resorption pattern happens in maxilla? So coming to the teeth position in maxilla, these maxillary teeth flare downward and outward. So bone resorption generally occurs in upward and backward direction. As bone is resorbing in upward and backward direction, maxilla gets smaller in size. Coming to mandible, as teeth incline upward and forward, so bone resorption will happen outwards and downwards, leading to increase in the perimeter of the mandible. In the sense, the jaw, lower jaw looks wider as there is resorption taking place. So this will lead to this condition where maxilla is smaller and mandible gets wider and wider, and this will lead to development of habitual class 3, where there is anterior rotation of mandible and mandible is positioned forward when compared to the midline of maxilla. Coming to prosthetic factors affecting residual ridge resorption. Excessive stress resulting from artificial environment. In the sense, if the denture is overly retained, there will be excessive stress on the tissues leading to more resorption. Hence, it is always advised to the patient, once he retires from his works in the day, it is advisable to remove his denture to provide adequate rest to the tissues. Long use, loss of bone and incorrect occlusion, also incorrect jaw relation. All these factors affect the residual ridge resorption. Long use leads to continuous pressures on the bone. Loss of bone, in the sense the amount of denture bearing area will be reduced, hence force per unit area will be increased. Incorrect occlusion. If there is improper occlusion, the force distribution will be disturbed. There won't be any balance. Hence, few areas will resorb more when compared to other areas. Incorrect jaw relation, in the sense it is about a vertical dimension. It should have proper interocclusal space. Just in case this space is obliterated, the muscles will become very active and lead to continuous forces on the denture bearing areas. Coming to the management of residual ridge resorption. First and foremost thing is the systemic evaluation. As systemic factors are more important, you have to evaluate the systemic condition of the patient. Just in case he has any systemic illnesses, try to take care of the systemic illnesses first. Then diet counseling. High calcium intake, vitamin D supplements might help in controlling it to some extent. Tissue treatment therapy. In subsequent follow-up appointments, you have to check for the tissue maintenance, how the tissue is being there. Check for any improper occlusions or malocclusions or occlusal prematurities developed in the dentures. Maintain, and then pre-prosthetic surgery. After initial evaluation, if required, if you have to increase the denture bearing area, perform some pre-prosthetic surgery to improve the denture bearing area, which will affect in proper force distribution. So, if coming to the treatment part, preservation is the first and foremost thing before you actually start with the treatment planning. So try to preserve the residual ridge. And what are the other treatment options available in order to reduce the amount of ridge resorption? Go with an overdenture. Just in case the patient has come with few remaining teeth, never advise complete extraction. Try to save few teeth so that you can go ahead with overdenture option. So once there is overdenture option, the forces will be distributed to tissues along with the teeth which are retained. So as the teeth are deep rooted into the bone, they will take up most of the vertical forces and the ridge will be preserved to some extent. Try and preserve some submerged roots if they are non-pathologic, and if you can do certain procedures like implantation of roots, cartilage, synthetic bone or hydroxyapatite foam at extraction stage itself. If extraction is inevitable, try to do some socket preservation so that bone resorption can be controlled to some extent. Then ridge augmentation procedures which actually fall in the pre-prosthetic stage. So coming to the conclusion, residual ridge resorption is a multifactorial disease and this has psychological effect on the patient. Preservation of ridge resorption is more important before you actually think about the treatment. Hence, follow methods which will help you preserve the bone than leading you to treatment. Then proper treatment is always must. Proper treatment planning. So every patient is different and the factors affecting and leading to his bone resorption is different. Hence, study thoroughly each and every case and devise or design a proper treatment planning, and not just treatment providing. You have to also conduct frequent follow-up appointments so that you can actually correct most of the procedures before it actually progresses to severe bone loss.